My name is Abraham George. I'm consultant public health in Kent County Council. I lead on health intelligence on behalf of the public health department here in Kent County Council. Excuse me. And I've been pretty much working with the National LTC program for the last 2-3 years in the development and design of linked data sets to inform commissioning, particularly for long-term conditions. So, without much further ado, I'll start talking. Give a little bit of a context around how we started off. So, the current situation, as some of you are aware of, is that there is a huge funding gap, both in the NHS and in public sector, and we need to be thinking about, well, how can public sector services transform themselves to and at the same time be expected to discharge their statutory functions with a much more smaller budget. In that regard, there is a growing need for now a whole system understanding of how money and resources are being utilized for population health and well-being, and greater insight around how we can develop higher value models of care, that is particularly around integrated services that can meet the funding crisis head on. So from the national LTC perspective, a lot of focus has been actually in the particularly the high intensive users or the complex elderly who happen to sort of fit in the sort of top 5% of the top population pyramid. But based on an 80-20 principle, that top 5% it's generally considered to consume a vast, significant proportion of the health and care resources that is available in the economy. And we know that from the way we work across different health professional domains, that services across health and care settings are pretty much commissioned in silo, and there's been a lot of debate and discussion around how we can actually integrate services and commission them in a more effective, efficient manner. So, and I've taken this slide out actually from NHS IQ, NHS England some time ago, which actually sort of explains pretty much what the Year of Care program is about, the LTC Year of Care program. And this is about shifting the focus away from reactive episodic care towards proactive, person-centered, capitative funding model, irrespective of organizational boundaries and disease-based pathways of care. And it's about incentivizing person-centered integrated care to, and then actually commissioning the whole patient journey rather than a specific service. In that regard, if you look at the diagram below the statement, so roughly speaking, there are broadly speaking, there are 3 foci of integration. On the top, you have joined-up commissioning, where we have health and care commissioners coming together to pool their budgets and talk about how they can commission their services in an integrated manner. At the bottom level, we have a lot of examples at the local ground. I'm sure all of you will have lots of examples around how some of your services are already integrating in terms of development of multidisciplinary teams or co-location of health and social care teams and so on and so forth. So that's about providing joined-up care. But the missing link in between both of these integration agendas is how do we actually commission joined-up care, and that's something that is not a straightforward answer. It requires a very detailed, comprehensive understanding of how activity and cost flows occur across the whole health and care economy. So a little bit about the profile in Kent, and Kent is not exactly a sort of bog standard unitary authority co-terminus with the CCG. We are in fact covering almost over 1.5 million population. Governance of commissioning is extremely complex. It's done at multiple levels. We have one county council that's responsible for adult social care, education, and transportation. But that one county council works alongside 7 CCGs and 12 districts to co-commission various other health and care services. And the provider landscape is also very complex, with having 4 acute trusts, 1 community health trust, mental health trust, and over 200 GP practices. And a lot of the commissioning that we do is also in collaboration with colleagues in Medway, and Medway is a unitary authority co-terminus with their CCG, so it is quite complex. In this regard, the Public Health Observatory team has been in existence, has been a shared service across the 3 PCTs up until 4 years ago, before we moved into local authority. The observatory team has been working for many years, providing the public health intelligence support for the commissioning organizations. It has been well networked with the other intelligence teams and is largely responsible for the development of the Kent JSNA. As you know, the JSNA stands for Joint Strategic Needs Assessment, which is a statutory requirement, and carries out various other profiles and analysis, such as health and social care maps, needs assessments, and various other reports. More importantly, historically, a lot of the data, that particularly hospital or SUS data, has been coming out from one location, which is the local data warehouse run by the Kent Medway Health Informatics Service. And this is an important data flow for us, and you will see later on, because of much of the year of care analysis is dependent largely on this particular data flow, among various other data flows we've developed over the last few years. So the progress to date, as I said before, we started the work supporting the QIP LTC program back in 2012 under the auspices of the program that was being led by Sir John Oldham. And in that, we were specifically providing detailed intelligence support for the local implementation of the QIP LTC program, particularly around integrated care. And in that regard, specifically, we did a whole population profiling of health and care service utilization using risk stratification. So pretty much what we did was looking at different risk strata, or different users of hospital services based on their risk score, and looking at how much they impacted not only the hospital but on social care and various mental health, community health, and various other services. In this regard, we found out interesting insights and results, looking at, for example, having a very reasonably good picture of understanding of the burden of multi-morbidity in our patch. And that's really important, because at the moment, nationally, there is no consistent way of how we actually report multi-morbidity using the available data that we have coming from, say, QOF, from SUS, and so on and so forth. We also found variation in service utilization known as a crisis curve. So that means, for example, when we identified those patients with the highest risk score, so patients who are high intensive users of hospital services, that usage of hospital service was not the same across different years. And actually, we saw a period of activity where it was actually in a sort of pre-crisis level, and then increasing into a crisis level, and then falling back to a sort of pre-crisis level after the crisis, if that makes sense. And we used some of that information to help us estimate the possible benefits of integrated care in terms of cost savings, in terms of savings of reduction of emergency admissions. The link to the full report is actually on our website, which is also appended in the slide. But that helped us and a long way to becoming, for Kent, becoming a early implementer site for the National LTC Year of Care program. At the moment, the implementation of the Year of Care program is done at a sub-Kent level. It also helped us to become an integration pioneer. And as a result of the Year of Care program, we've been submitting linked data sets to the national team, which resulted in the population commissioning report, which we're going to discuss right now. And we've also been contributing towards national guidance around data sharing, about how we actually link data and the IG issues and the technical issues around doing that. As I've mentioned before, the Healthmatic service is a key collaborative partner with us in doing most of this program. So so what I was thinking was I'll just talk very briefly about some of the graphs and charts. I've picked out handpicked three charts from the Population Commissioning for the Future report, just to highlight some of the findings that we found out. So as I've said before, the Population Commissioning report is basically a longitudinal analysis of service utilization and costs for patient cohort based on identified through two approaches. One was just looking at their multi-morbidity profile based on hospital admission data, and the other one was based on risk scores. What we found out was that actually a lot of the results were actually somewhat similar, particularly, for example, the crisis curve, which I'll show you in a graph. This first particular graph is just showing the proportion of the Kent population who have a specific base long-term condition, but also have other long-term conditions. So what it's basically showing is the multi-morbidity profile of the Kent population, Kent whole population, and what you're seeing is that with those patients who are who have a particular named long-term condition shown on the y-axis, that's either ranging from heart failure to depression, anxiety. A vast majority of them are having some other long-term condition as well. And so, it's actually sort of corroborating some of the findings that have been emerging from other places, particularly research done in Scotland around multimorbidity. That multimorbidity is now the norm, not the exception in the population. This particular graph is illustrating the concept of the crisis curve. So imagine the same population, the same particular high-intensive user group, so with a high risk scores, and if you're following them up over time, looking at their use of services across health and social care, you will find that actually their use of services are not exactly consistent or the same across all the years. And what you're seeing actually is a significant increase in emergency admissions for the highest risk scored patients during their year of crisis, which is, as you can see, in the year 2010-11, and actually which is much higher than the emergency admission activity across before the period of crisis and after. Now, the reason why in this regard you're seeing actually crisis activity going down in the year after crisis, and that's a phenomenon called regression to the mean. And the reasons what we think that have happened here is either the patient have actually got better because they've been admitted in the hospital and got their treatment, or they might have died. And considering that that very high risk, that high intensive user cohort, the majority of those patients were actually the complex frail elderly. But more interestingly, as you can see with the use of the other services, there is no crisis curve being seen in community health or social care or in mental health. That actually the use of services in that regard were quite similar across the different years. And this graph is basically showing you the average annual cost per patient across patients by numbers of long-term conditions. And this is while we've not actually done any statistical analysis on this, but you can actually see that there is quite a strong there appears to be a strong relationship between numbers of long-term condition and the cost per capita spend. And so, for example, patients with no long-term condition, the average per capita cost is very, very negligible, whereas those with more than 6 long-term conditions ranges up to £10,000 during their year of crisis. So in a bit about the Year of Care program in Kent. So all the providers and commissioners are involved. All the 7 CCGs have signed up, including social care and also 2 of the acute trusts. 2 of the CCGs are sponsor organizations. Unusually in Kent, Public Health is actually managing the LTC Year of Care program, which is actually been seen as a CCG-led program. But because we've been doing this, we've been doing a lot of groundwork already for the last couple of years. It was seen as a positive thing for Public Health to lead on this. Implementation is done at a sub-Kent level. We are not, as each CCG would want to have a practical application of the LTC Year of Care program in their own patch rather than at a Kent level. The East Kent group of CCGs were the first to take part and now finalizing shadow test arrangements. All professionals are involved, so it's not just commissioners, but we're actively involving finance leads and particularly informatics leads across all the different teams, different organizations. We've contracted the Kent Medway Healthmatic Service, who run the local dashboard and the risk stratification tool, to develop a dashboard to monitor activity and costs as part of the shadow testing process for the Year of Care program. At the same time, because we are using linked data sets, we can actually evaluate integrated care models that the CCGs are already implementing. The data linkage at person level is still not yet finalized because of IG debate and discussions going on, not only at a local level but also at a national level. So linkage of data across the key services is currently at a GP practice level, but that's also already giving some interesting results, which I'm going to show you in a slide right now. So, so just to clarify that the way we are actually shadow testing the LTC Year of Care program based on the findings that we've found that are on the population commissioning report. So we're identifying Year of Care patients based on their upward swing of risk score or rate of increase of risk score. And so the risk score is basically mapped over the last 6 months, and if there's a rate of increase, particularly of more than 15 points, then we hypothetically include them into a Year of Care cohort. And then we segment them based on the numbers of long-term conditions that they have. Now, this is actually, the long-term conditions are actually being derived from the primary care data, which the local data warehouse already has access to. The primary care data is coming from almost 80 GP practices, which covers a total population of 700,000. Out of that 700,000 population, about 6,000 of them have been sort of hypothetically identified for a Year of Care cohort. And the plan is that we've now started shadowing them over from May onwards, and we've already got about 6 or 7 months worth of data. But and in this slide, we're showing about 4 months worth of data from at least 5 services. One of the 5th service being the hospice. So the East Kent Pilgrims Hospice have also been sending in their data as well. So the graph on the left-hand side actually shows the per capita cost, the average cost for a Year of Care patient versus a non-Year of Care patient. So bearing in mind that the Year of Care patient, there are about 6,000, those costs, those bars, the level of cost for Year of Care patient are based on a cohort of 6,000, and the level of cost for the non-Year of Care patients are based on the remaining population, the whole population, which is 720,000 minus the 6,000 Year of Care patients. On the right-hand side, there was a further analysis done by the informatics service with the public health team, looking at average cost per record. Now, what I mean by record is basically the records that were linked across hospital, mental health, social care, community health, and hospice. So, So in the year of care patients, over a 4-month period, around 52,000, more than 50,000 records were linked, and the cost or the unit cost activity per record was mapped out. And in the non-year of care patients, it was actually it's the remaining something like about 800,000 records for the remaining rest of the year of care patient, rest of the whole population that are not year of care. But both these graphs are actually showing some interesting insights. So the graph on the left-hand side is actually appearing to suggest that year of care patients cost much more than non-year of care patients, which we would expect. But the cost per record is actually showing something different. Initially, we haven't actually looked at this. We haven't analyzed this to a great extent yet. But we are thinking that it might be because of those records that are being linked up in the rest of the population are actually due to all kinds of other activity, like, for example, activity as resulting from road traffic accidents or long-term care needs like sort of learning disabilities, mental health illness, things like that, which would incur very high per capita social care costs. But roughly speaking, the above graphs show about 4 months worth of activity and costs are worth around 57 million from 7 different provider organizations. Of this, 4 million, or 7% of the total spend, represents proportionate costs for the year of care board, which is around 0.8% of the total population, not 0.3, which is a mistake actually on the slide. But the year of care program is highlighting all kinds of other practical and technical issues. So, for example, we've identified issues around no standard definition of integrated care being in terms of data collection and coding. Care plans, how are care plans actually being coded and shared between integrated teams. Regarding, it's also about, we're also identifying issues around systematizing data flows from practices to the data warehouse, as well as from other providers like the Mental Health Partnership Trust, and also variation in recording in quality of data from the GP practice data as well. So all kinds of things are being picked up, which are actually not, I don't see them as, we don't see them as blockers, but actually, they're actually really important issues that we should be picking up as a result of this program, and actually helps in the continuous quality improvement of data quality and of validating data quality. This graph is just showing you the IG arrangements that we have set up. Now, the idea is that all the providers are actually sending in their data, clear data, into a black box that's been developed by the informatics service with a view not to violate or contravene current IG regulations. So using that black box approach, all the data is sent in, and then the data can be linked up. But albeit we haven't got clearance yet to link it up at a patient level, sorry, not we, the informatics service, haven't got clearance yet to link it up at a patient level. So everything's being linked up at a practice level. So the results that we're getting right now have been that are being extrapolated from analysis that's being done at the practice level. The key challenges, I can say, reiterate it over and over again. Information governance, which I used to think was an enabler, but now I think is becoming almost as a blocker. Current approach to data sharing has been difficult. When you consult different IG experts who are all from different organizations, pretty much, and it's not their fault or anything. It's just a fact of how national policy is set up, is that they interpret national policies such that it has, with a view to be as risk averse as possible. And so as a result, the latest advice we've been given is, if we want to link up data at a local level, best to do it through the new and emerging DISCROs, or data service for commissioning organizations. And so we are trying to get some of that, some of this work being done via the regional South London DISCRO, but we're still not yet had any clearance yet around that. There are issues around whether we can, whether local organizations like County Council can link up data, and that's something linked to regulations that are being developed by the Department of Health on accredited safe havens, and I have some very strong views that I'm articulating at a national level around how those regulations should be designed. Data quality and accessibility is a major issue. While the provider organizations are all happy to say, yes, we don't mind sending you the data, but when we get the data from them, we're seeing huge issues around data quality, completeness, coding, as I've mentioned before. Commissioner buy-in is, at the moment, and I don't speak for any commissioners at CCGL, but the impression that I get is that they are extremely busy in firefighting at the moment, very reactive. They're involved in so much reactive work that to get them involved in participating in a program that is very very long-term thinking and very proactive is a huge leap forward. But slowly the mindset is changing, albeit very slowly. But it is very difficult to predict how the success of our program, considering that there is so much change going on, particularly around how the commissioning support services are changing and transforming within the Kent area. So finally, just to say that the key messages is that there's a huge amount of big data that's being collected across health and care settings, and if we can actually design and develop whole population person-level linked data sets using NHS numbers, this is something that can actually radically transform the health and care economy, and we are actually actively contributing to some the guidance that monitors develop, hopefully be releasing shortly, and how that will influence the whole integration pioneer agenda. It's not just about linking up the data, but when you actually bring the data, how can we actually use technology to interrogate it in a quick, efficient manner, so that we can validate data quality and various other issues in a more timely way. The work that we're doing is actually exemplifying the role of business intelligence and particularly public health intelligence in how we can all work together to develop higher value models of care to incentivize prevention and improve population health and well-being.